Hello everyone, I'm Dr. Avilash Tiwari and we are back with our series of talk on general internal medicine. And today we are going to discuss about the spontaneous subarachnoid hemorrhage. Friends, in subarachnoid hemorrhage, usually the bleeding or the hemorrhage usually occurs between the innermost part, that is the pia mater, and the middle layer, the arachnoid matter of the meninges that covers the surface area of the brain. So we are going to discuss about from the physician's perspective and especially the candidates preparing for the postgraduate examinations like MRCP. So that I'll be trying to cover almost all the points that will be helpful from the examination point of view as well as from the clinical practice point of view. So to start with, I'll just like to share my slides out here. So we are going to start an approach to subarachnoid hemorrhage today, and we're going to discuss from the physician's perspective how to diagnose this case, manage this case, so that you can confidently treat this case in your routine practice. So in subarachnoid hemorrhage, as I've already said you right now, it's a bleeding between the space innermost, the pia mater, and the middle layer, the arachnoid matter, where the bleeding occurs. Subarachnoid hemorrhage represents approximately 25% of the hemorrhage stroke and 5% of all these strokes. Trauma is the most common cause of the subarachnoid hemorrhage, accounting for about 70%. And other than the non-traumatic causes, is spontaneous subarachnoid hemorrhages are most commonly caused by the rupture of the intracranial aneurysm, almost 80% of which are saccular or the berry aneurysm, and that usually occurs at the bifurcation of all the major branches of the circle of Willis. Other causes of spontaneous subarachnoid hemorrhage include a perimesencephalic subarachnoid hemorrhage, cerebral amyloid angiopathy, cerebral venous sinus thrombosis, cerebral arteriovenous malformation, cerebral vasculitis, mycotic aneurysm, coagulopathies, dissection of the intracranial carotid and the vertebral arteries, or the extension of the intracerebral hemorrhage into the subarachnoid fluid. The very common thing in the clinical practice as well as in the clinical examination, the questions they ask is what are the causes or the reasons for the subarachnoid hemorrhage. Remember, the most common reason is a trauma. Other than that is the rupture of the berry aneurysm, which is often present at the bifurcation of the major arteries in the central nervous system. The circle of Willis has been mentioned here. And other than that is the disorders of the arteriovenous malformation. A perimesencephalic subarachnoid hemorrhage is often benign, and in which cases we found a subarachnoid bleed is there, but you are not able to delineate or find a exact reason for that. That is to say that you're not able to see any berry aneurysm in which. Cerebral amyloid angiopathy, usually these cerebral amyloid angiopathy are often a cortical type of bleeding rather than it goes inside the deep gray matter. No, it is usually the cortical surfaces of bleeding. The deep gray matter is often attributed to the hypertensive bleed. Cerebral venous sinus thrombosis can have a hemorrhagic infarction. So that is also one of the reasons that can at times lead to the subarachnoid bleed. Cerebral arteriovenous malformation, these are congenital disorders, may present with the subarachnoid bleed. Cerebral vasculitis, the patients with a connective tissue disease, collagen vascular disease, should have a high index of suspicion in which they can present with the subarachnoid bleed. The mycotic aneurysms are often seen in the case of the infective endocarditis, where the infected embolus gets a deposit in the vessels and thereby it ruptures and the patient bleeds. The most common reasons in present era is the presence of the anticoagulant, the coagulopathy. So you should never forget to check the coagulation profile, especially the platelet count, prothrombin time, activated partial thromboplastin time, and the thrombin time whenever you come across all these types of the subarachnoid bleed. The dissections of the intracranial carotid artery and vertebral artery, the very famous topics on based upon which a lot of the question comes in the MRCP exams. Even the most common reason is they can lead to a ischemic stroke, but equally they can cause a subarachnoid bleed. So these are the very common things we should know about the basics about the subarachnoid bleed. Now, before you go ahead, there is an Ottawa subarachnoid hemorrhagic rule which helps us to delineate or tell us the probability the individual may have a subarachnoid bleed and based upon which you try to diagnose it. This Ottawa subarachnoid hemorrhage rule tells that an individual or a patient who is more than 15 years of old and who has a first time severe a traumatic headache and which reaches the maximum intensity within 1 hour. And the usual patient characteristics are the age is more than 40 years, neck pain or stiffness. There is a witness loss of consciousness. The onset is during the exertion, thunderclap headache, peaking within 1 second, and limited neck flexion. All these raises a high probability that the patient may have a subarachnoid bleed. And if it is yes, the evaluation is done. Now, why and what is the need for this subarachnoid this bleed has been there. Why we need this thing is, friends, a lot of the patients may have a sentinel. I'm using the word the sentinel bleed, which is there in the brain, and they're often undiagnosed. They present to you with a headache and may have a mild neck stiffness, and often the physician says there's nothing to worry because majority of the cases in the initial stages may not have any focal neurological deficit other than some limited neck flexion or nuchal rigidity, you can say, and then they later come on in the casualty with a frank either complications like a re-rupture of the aneurysm, or they may have an obstructive hydrocephalus, and they already have developed secondary brain injury. So that's the reason that you must have an Ottawa subarachnoid hemorrhagic rule. Secondly, you have to have a pretest probability to ascertain why a person can have a subarachnoid bleed. Remember, any individual with a thunderclap headache reaching to the maximum intensity, you must always think that this patient may have. The CT scan is definitely an initial investigation of choice, but the earlier you do, the better is the outcome or the result or the yield or the sensitivity. If the patient comes to you after, say, around more than 24 hours have been passed, so the yield of CT scan may be negative. In such cases, where more than the 12 hours have been passed, we advise the patient to undergo a CSF examination. Why am I telling this? Why we should not miss? The purpose is to tell you you should not miss the subarachnoid hemorrhage. This is very important take home message with I want to carry, because these patients are at very high risk of rebleeding and developing secondary neural injury. So as a doctor, you should not miss a subarachnoid hemorrhage. Definitely the fulminant or overwhelming subarachnoid hemorrhage can easily be detected, but at times the subclinical or mild degree of subarachnoid bleeds are often been missed. So in common questions in the MRCP or the clinical examination, that if a clinician anticipates the patient has got a subarachnoid hemorrhage and the initial CT scan is negative, do not hesitate to advise the patient to go for a CSF examination. So these are the clinical manifestation, as I've already said you. A thunderclap headache associated with nausea, vomiting, photophobia, neck stiffness, and back or the leg pain. A sentinel or warning event can occur days before to come. This is a very common and it has often been missed because, as I have said you, the focal neurological findings may not be present at the time when the patient have a sentinel bleed. Mental status may be a normal or to the frank up to the coma the patient may be having. At times, patient can present with a cranial nerve, oculomotor nerve palsy, suggest a posterior communicating artery aneurysm. Common questions asked during the MRCP examination, the patient with a headache, thunderclap, and then you come across a typical oculomotor nerve palsy. So the most common answer is the posterior communicating artery aneurysm. So this is one of the important thing. A focal hemispheric sign such as hemiparesis, aphasia may be present depending upon the site of the rupture of the aneurysm or the presence of the subarachnoid bleed. The fundoscopy may reveal the pre-retinal hemorrhage, or what we call it as a subhyaloid hemorrhage. And the most important thing is the delayed neurological deficit. The patient may have present with any of these four things. Number one, there can be a neurological deficit presenting as a re-rupture, hydrocephalus, delayed cerebral ischemia, hyponatremia. Again, I repeat, please do not forget from the clinical perspective as well as from the examination. The delayed neurological deficit is one of the important manifestations of subarachnoid bleed. Either the patient may come with a re-rupture or the patient may present with an hydrocephalus, delayed cerebral ischemia, presented as due to severe vasospasm, or the hyponatremia. So, how to diagnose it? As I've said you, when you have a high index of suspicion based upon the Ottawa subarachnoid hemorrhage, and there is a high probability, the first investigation should be the CT scan. Non-contrast CT scan brain should be done. If it is there, if it is positive, call the neurosurgeon and start with the standard line of management. Resuscitate the patient, nimodipine 60 milligram to be started every 4 hourly for 21 days. If it is negative and there is a strong indication that this patient might have had, as I said, if the patient comes after 6 hours or say after 12 hours or even more, as the time passes by more and more, the CT scan yield to detect the subarachnoid bleed declines. So in that cases, the CSF is often been recommended in order to demonstrate the presence of xanthochromia. For the xanthochromia, that is yellow supernatant fluid, which is occurring in response to blood which has been hemolyzed, and it requires around 12 hours or more to be present. So after 12 hours, you can advise your patient to have a CSF examination, and you will find all the four bottles will have the similar type of presentation. Next important thing, when you see or when you diagnose, now it is you have already been diagnosed as this patient has got a subarachnoid bleed, and the most important, you have to liaise with a neurosurgeon, a dedicated neurological intensive care unit where specialized facilities are available. And you as a physician should try to classify your patient or grade your patient based upon the Hunt has grading scale for the aneurysmal subarachnoid hemorrhages. So when you start the treatment, the first important thing you should never forget that you're going to assess and put your patient or classify them that in what category the patient falls as per the Hunt Hess grading scaling. The reason why it is required is it determines the outcome. Supposing if the patient is in a grade 1, like asymptomatic to mild headache, the prognosis is good. The mortality, as you can clearly see, is 3% in the hospital. If it is in grade 2 moderate to severe headache with oculomotor palsy, the mortality rate in the hospital is 3. If it is confused grade 3 drowsy with mild focal sign, the hospital mortality is 9. And you can clearly see as the grade of the Hunt has increases, the mortality rises steeply. So the stupor, the comatose, that is grade 4 and grade 5. The mortality you can clearly see is 24 and 70. Why we need a Hunt and Hess? Because when you need to do a coiling or when you need to put a platinum coils in the aneurysm to prevent the rupture and rebleeding, we decide if the patient is already a stuporous or in comatose posture or a grade of the Hunt Hess, the outcome may not be that favorable, and it is not that advisable or prudent or anything that was going to yield any very positive results by doing that intervention. So the goal of the treatment here is to minimize the early brain injury, to prevent the rebleeding, perform a definitive surgical or the endovascular intervention quickly, and prevent and treat the secondary complications. So, what is the treatment option is there? Remember one thing, once you have diagnosed there is a subarachnoid bleed and proven by the CT scan or through a CSF examination, you're going to order a cerebral angiogram, either CT angiogram, and the gold standard is four vessel cerebral angiography or DSA can be ordered. And if it has been found, a neurosurgeon should be called in. An emergency endovascular coiling or the surgical clipping of the ruptured aneurysm is usually required to prevent the rebleeding. This is the most important thing you're going to do in your patients, that you're going to liaise with the neurosurgical team and you're supposed to arrange for the endovascular coiling. Except in the patient with an extreme poor prognosis, as I said you, the Hunt has grade 3 and 4 sorry, 3 and above, 4 and 5. So they usually carry poor prognosis. But who are falling within the grade of 1, 2, and 3, there is definitely a positive outcome. The common questions pertaining to the postgraduate examination is that you are supposed to tell that emergency endovascular coiling or the surgical clipping is to be ordered. Vast majority of cases nowadays, they prefer to have an endovascular coiling over the surgical clipping. We'll not go into the details of that discussion because based upon whether it is anterior or the posterior circulations, the neurosurgeon or the intervention neurologist decides whether the coiling is superior or the surgical clipping. But from the medicine perspective, it has been mentioned that the endovascular coiling is found to be superior. Now, about 30% of the patients with an aneurysmal subarachnoid hemorrhage die within a month of their bleed. Untreated survivors have a recurrent or rebleed at the rate of 40% in the first 4 weeks. This is very important. So that's the reason I was trying to emphasize the diagnosis of the subarachnoid bleed should not be missed. I repeat, at about 30% of the patients with an aneurysmal subarachnoid hemorrhage usually die within a month, and untreated survival have a recurrence of the rebleed at the rate of 40% in the first 4 weeks. To prevent the rebleeding, the targeted systolic blood pressure should be less than 160 mm of mercury, the preferred goal of 140 to 160 mm of mercury. Now, this is very common questions and the concerns that often been used in the intensive care unit about the controlling of hypertension in a patient with a subarachnoid bleed or a patient with an intracranial hemorrhage. Although we are talking about this subarachnoid bleed, Please understand the nitroglycerin and the sodium nitroprusside are often not indicated in order to lower the blood pressure. Rather, labetalol, nicardipine, as all these molecules are often preferred, and a continuous intravenous infusion is there so as to have a sustained blood pressure control, because the nitroprusside and nitroglycerin at times may exacerbate the intracranial blood volume and the blood flow, and they may further precipitate the subarachnoid bleeding. And that's the reason they have not been recommended as per the guidelines. So even certain centers we have found the sodium nitroprusside been used, but the guideline clearly states that they should not be used. Unlike the one of the most important complications in the treatment is an hyponatremia, what we call it as a cerebral salt wasting syndrome, which is often seen in subarachnoid hemorrhage. In all the other hyponatremia secondary to the syndrome of inappropriate antidiuretic hormone secretion, what is the mainstay of treatment? And we all know the fluid restriction. This is the only place where we tell the fluid restriction strategy is not advocated in order to manage hyponatremia in individuals with subarachnoid bleed. Why? Because that may result in increased blood viscosity and predispose to the cerebral ischemia from vasospasm. So this is one of the very important. The cerebral vasospasm usually occurs from third, fourth day and peaks around seventh day. So there are various ways to detect it. We are going to discuss about in short about the management protocol for the acute subarachnoid hemorrhage. The first and foremost thing is control the blood pressure. Admit the patient, airway, breathing, circulation. Measures to control the blood pressure. The control of blood pressure you can clearly see is done, and try aim to bring down your systolic blood pressure to less than 160. This is very important thing, but it should not be in hypotension. You have to maintain it between so as to have an adequate cerebral perfusion pressure. The drug of choice is intravenous labetalol or the nicardipine. This is very important. Second is once you have done, you have to soon liaise with the team to in order to prevent a rebleeding. So by the time the team arranges for the angiogram and then they decide for the the platinum coils to be inserted, you have to prevent. The guidelines mention the epsilon aminocapric acid can be given. It has got a very modest benefit. Though certain guidelines do not advocate, certain guidelines do advocate, but this is a bridge therapy by the time a definitive surgical or the clipping has been pending, or so this works like a bridge therapy where you can do it. So epsilon amino capric acid can be used. Next important thing is that intravenous hydration should be maintained by using a normal saline at the rate of 1 to 1.5 ml per kilogram per hour. This is very important thing. The adequate hydration. Please understand. On one hand, you're trying to control the blood pressure. On the other hand, very common notion is the patient should be adequately hydrated. This is very important thing, because if the patient is not adequately hydrated, the patient may develop severe cerebral vasospasm. So a normal saline is often given at the rate of 1 to 1.5 ml per kilogram per hour. So laboratory monitoring can be done by doing a complete blood count, check for the electrolyte, look for the coagulopathy, and obtain the serial ECG. Why the ECG happens? In response to the subarachnoid hemorrhage, the patient may have an STT changes, the patient can develop arrhythmias, the patient can have a positive troponin level. At times, the patient can have a neurogenic pulmonary edema. So all these things you have to consider it. So the patient usually requires a continuous ECG monitoring. So the laboratory monitoring should go hand in hand. Next important thing is that the individuals who are stuporous or the comatose or the grade 4 and grade 5, or who has got a very frank subarachnoid bleed, are at increased risk of development of the seizures. And you know the seizures in turn can further increase the intracranial pressure and can further precipitate or re-rupture an aneurysm and may further add upon the subarachnoid bleed. So a prophylactic levetiracetam is usually given. The guideline mentioned the dose of around 2000 milligram intravenous loading dose followed by 1000 milligram IV twice daily. And you can discontinue this on the post-operative day one unless the patient has seized or has got a very poor grade or has a focal cortical pathology, which is otherwise, or is an unstable. Next important thing is the vasospasm prophylaxis. Seizures treatment line, you can do the best thing. What we recommend in the ICU is you can have a bedside EEG monitoring. The patient is stuporous or the comatose. We usually continue with the anti-epileptic treatment. If the patient is in Hunt Hayes 1 or 2 or 3rd grade and the patient doesn't have a very gross bleeding, you can attempt to stop the anti-epileptic medication. So you have to take a very crucial judgment based upon these parameters as well as the bedside electroencephalogram. Sometimes the seizures are very difficult to control, so you may require a proper follow. Midazolam has often been used in order to, a centrally acting agent, I mean to say, in order to control the seizures. Next important thing is the vasospasm prophylaxis. So nimodipine should be started at the dose of 60 milligram orally every 4 hours until 21 days. All the clinicians and friends remember nimodipine at the dose of 60 milligram orally through Ralph's tube or the nasogastric feeding tube every 4 hourly for from until 21 days or till the time of discharge. The peak time of the vasospasm occurs anywhere between third or seventh day, which is very important thing. So the delayed cerebral ischemia, this is very important thing we should remember. Why I'm telling 60 milligram, a lot of the formulations available in other countries are 30 milligram, I've seen. So it should be 60 milligram. Now, the physiological homeostatic, what you need a cooling blanket in order to control, because the patient often develops fever, they may not respond to a standard paracetamol. You may require an insulin drip to control the sugars. And remember, friend, all the individuals who have got a typical obstructive hydrocephalus with a subarachnoid bleed or an intracerebral bleed who are comatose or stuporous. Remember, the most important aspect is the ventricular drain. So, emergency external ventricular drainage placement should be done without delay, and that should be done. And equally, when you put a ventricular drain, an intracranial pressure monitoring device should be placed, and then you have to take a call whether you can clamp it or not. And should there be a ventriculoperitoneal, a ventricular dilatation, or the cognitive impairment, vast majority of the patient requires a typical ventriculoperitoneal shunt for the long-term basis. Next important thing is a vasospasm diagnosis. How can you diagnose if this patient is going to develop delayed cerebral ischemia or vasospasm, as I said you? What happens is when there is a subarachnoid bleed, the end product of the blood irritates the vessel wall, which in turn causes severe spasms. So how can we predict it? There are a lot of ways we can predict it. There are CT scan guidelines are there, and the very common as a clinician what we use is a transcranial Doppler, which should be done every 1 or 2 days. That helps in predicting that this patient is at increased risk or that the patient is developing a vasospasm. Other than that, you can order for the cerebral angiogram, though we do not do it that frequently. The best is to have a transcranial Doppler. So once you see if the patient has developed, the vasospasm, the patient is at increased risk for secondary neural injury. The most important thing, place your patient in Trendelenburg position, that is a head down position. Immediately try to give 1 liter of normal saline over 30 minutes. Hydrate the patient immediately. And if the deficit persists, raise the systolic blood pressure with phenylephrine or norepinephrine until the deficit resolves. And the target is to bring the systolic blood pressure around 180 to 220 mm of mercury. Yes. Here we are trying to induce the hypertension so as to overcome the vasospasm, so as to increase the blood flow within the brain. So this is the idea behind it. So we are inducing a hypertension using a vasopressor like phenylephrine or norepinephrine. And what should be our target? The systolic blood pressure should be 180 to 220 mm of mercury. And if it's still refractory, then you have to monitor the cardiac output and you have to use the other molecule which can increase the cardiac output like dobutamine or milrinone. You have to use it. And if the patient is having a low hemoglobin count, you can transfuse the patient to bring around the hemoglobin of around 10 gram per deciliter. Emergency angiogram can be done if it is refractory, and then there itself you have to decide for the intra-arterial verapamil, or even they are using nicardipine intra-arterial in order to overcome this vasospasm. At times the patient may require a cerebral angioplasty, and that's the reason in the beginning of my talk I said you the patient should be admitted to a dedicated neurological intensive care unit where all the facilities are available. So the treatment of the fever, as I said you, acetaminophen is required, physical cooling measures are there, and a massive sympathetic outflow which occurs after the subarachnoid hemorrhage may lead to the neurogenic pulmonary edema, cardiac dysfunctions, electrocardiographic changes, and elevated cardiac troponin levels are often been seen. And you can clearly see the patients may develop a neurogenic pulmonary edema. So how can we prevent about it? This is very important thing. But once you prevent, the preventive screening should be done in all those individuals who had a strong first degree relative of intracranial aneurysm or who had a past history of subarachnoid hemorrhage. They can be seen. And if the patient does not have any bleed, Screen them that these individuals are at increased risk. Say, for example, the individual might be having a polycystic kidney disease with a berry aneurysm. Keep a serial neuroimaging, and once you find that the serial neuroimaging is able to delineate or demonstrate the slow growth or rising in the growth or the size of the aneurysm, that places this individual at around 2.5% risk of rupture. And in that case, a definitive treatment like coiling or clipping can be done. So not in all the cases you need to have a serial studies in order to demonstrate that there is a significant intracranial aneurysmal growth has been seen. Second is the control of the risk factors, the most important of which is then hypertension, cessation of smoking, heavy alcohol, probably even in the patient with the polycystic kidney disease. So this is which is quite important thing which I wanted to share with you all. Uh, So, in short, we have tried to cover the subarachnoid bleeding, friends. You should have, again, a take home message. You should have a high index of suspicion. A patient presenting with an intense headache, reaching up to the maximum intensity within an hour, associated with some signs of meningism, neck stiffness, Kernick signs may be positive. There can be altered level of consciousness. Beware of the pitfall. The patient may not have a neurological deficit. It is not necessary that every patient will have a sixth cranial nerve palsy or third cranial nerve. No, it may be present, it may not be present. Based upon the Ottawa subarachnoid rule, you have to decide the probability this individual might have, and based upon the other risk factors, what I have explained you right now, you have to decide. Once you have decided this patient is at a high risk, obtain a CT scan, still negative, high index of suspicion, order for CSF, and once if it has been proven, then you can start immediately for the platinum coils or the surgical clipping, nipodipin, and the medical management. You have to maintain the hydration, you have to control the blood pressure, and you have to predict that the patient is at increased risk of development of delayed cerebral ischemia. So you have to predict the vasospasm. The best is transcranial Doppler studies. If possible, the angiogram can be done, and then should there be a indication that this patient is developing a significant vasospasm. As I said, you tunnel book position, normal saline 1 liter, induce the hypertension using phenylephrine or norepinephrine, increase the cardiac output, and if not, it's still not controlled, then the patient should be done the angiogram, and there and there itself intra-arterial vasodilators like verapamil can be given. Sometimes the angioplasty may be required. All these things makes a very good patient outcome and better outcome. So ensure that your patient should receive optimum treatment from the physician perspective. Deep vein thrombosis prophylaxis, sepsis control protocol, all has to be implemented in management. Thank you very much for your kind listening. Thank you.